Hello everyone. I think we'll make a start. It's 9:32 and the event starts at 9:30, so that's great. So hello and welcome to our June Matinee OSIP event. So hopefully you can see the slides on the screen. So just by way of an introduction, I'm Julia Wood and I'm the Matinee OSIP lead for North East North Cumbria, and I would really like to thank you for taking the time out for coming along today and joining this event. I know everyone's really busy, so it is very much appreciated. And just before we get started, it would be great if you would just start sharing in the chat box who you are so others can get a feel for who's joined, just so everyone can see who's on. That would be brilliant if you could do that. Next slide, please. So just while you pop in that information into the chat box, I just wanted to go over some housekeeping. So please ensure your microphone and video are turned off during the kind of presentations, unless asked otherwise. You know, we all know that's because of bandwidth, and just making sure that we don't get interrupted as we're moving through the morning. And if you do need to take a break, that is absolutely fine. There's no problem with that. Or if you need to take a phone call, but please feel free to drop off and just rejoin using the link. And if you want live captions, please just put a note in the chat or email Sarah Black. Her email is on this slide as well. And please could you ask questions through the chat facility? That's really because of the numbers of people who have joined this meeting. And what we will try and do is address all the questions you ask during the event. But if we don't actually manage to do that, we will definitely follow that up after the event. And if for whatever reason you can't see the chat, please email Sarah Black. Her email is on the screen there. And just so you know, speaker presentations and recordings will be circulated following the event. So if you do miss any of it, it will be recorded. And just a point for the session today, towards the end of this morning, you will need a sheet of paper and a pen plus a sheet of A4. So if you could get those either now or at the break, that would be really useful. So you're all ready for that. So thank you everyone for putting all that information in the chat. That's brilliant. And yeah, that's great. Still coming in. That's brilliant. And I just wanted to go over the agenda. So you will have already received an agenda from Sarah Black. You probably got two versions. So the old version and a new version was sent out yesterday. And the reason for that is because unfortunately, Charlie Merrick, who's from the national team, he's had to take some urgent unplanned leave. So we've had to have a change of plan about the agenda. So the first thing I wanted to make sure that you are aware of is because Charlie isn't able to join us today, rather than to fill time, because I absolutely hate that when people do that to me, we've made the decision to cut the event short. So the event will now finish at 11:30 at the latest. So we've cut the event short by an hour because that's Charlie's presentation is going to take that length of time. So we've done that. So today, what I'm going to do is start off by providing you with an update on what is happening in the Matinee OSIP world, particularly within North East and North Cumbria. But in Charlie's absence, what the national team have done is sent me through some bullet points, so I've incorporated them into the presentation. So hopefully you'll be able to get a flavour of the national picture as well. So that should probably take us to about 10 to 10, and at that point Tony Roberts, who I think you've all met before, but I'll introduce him when we come to that section, is going to run a session on the management of deterioration in women and babies with a specific focus on escalation. Now, during this session, we would really value your thoughts so we can identify if there's any areas which we can support trust regionally. So it'd be great if you would be involved in that. And then that'll take us to about 10:10, where we're going to have a short break. And when we come back, the remainder of the event will focus on measurement. Now, I know some of you may well switch off just at the mention of measurement, but measuring what you do is it's so incredibly important, particularly when we're looking at implementing change. And it doesn't have to be hard or complicated, and this session will hopefully demonstrate that. For others, I guess for some of you, this session might be the highlight of your morning because people tend to either love or hate measurement. But I do have to say, if I'm honest, a few years ago, I definitely used to be in the switch off camp about measurement because I thought it all seems sort of difficult and complicated, but I did see the huge benefits of it, and now it's not something I shy away from at all, and it's nowhere near as difficult and complicated as I thought it was. So please do stay for that session. I think you'll find it quite useful and informative. So that is the agenda for today. So if we move on to the next slide, please, Stuart, that would be great. So what I'm going to do now is give a brief, well, not brief really, an overview of what's happening in the MACNIOR SIP world. So next slide, please. So now I did share this slide at the event in March, and I really wanted to share it with you again. And the purpose of that is just to reiterate that, as you know, the focus of phase 2 of the MACNIOR SIP is very much on system level. And these are some, but not all, of the organisations which we work with closely with as a region. And as you know, this is a national programme. So if we think about the number of organisations which are involved in this at a national level, it's absolutely huge. So moving on from that, so by way of an update, I wanted to start with this. So this year from April, smoke-free pregnancies, which was in the MACNIOR SIP specification for last year, isn't for this year. Now, it hasn't been removed because no one thinks it's incredibly important, because everyone thinks it is. But nationally, they felt it is being picked up. Could you just go back to the last slide, Stuart? Yeah, brilliant, thanks. But nationally, it is being picked up through Public Health England and smoking prevention teams. So what I'm going to do is share the new specification with you in a minute, but before I do, I just wanted to mention the smoking work which took place last year. So when I'm talking about last year, it was in the year from April 2021, which ended in March 2022, but actually this work continued a little bit after then and it's just been completed. So some of you will remember that our focus for the smoking cessation, for the smoking work stream, was on smoking cessation enhanced support, and I'm delighted to tell you that this has now been incorporated into the regional pathway, and I really wanted to take this opportunity to say a huge thank you to Becca Scott and Karen Armstrong for jointly working on this with me and for pushing this work forward. But also I wanted to say thank you to everyone involved who attended the meetings and gave their feedback. The meetings were really well attended by people across the region, so that was brilliant. And I do need to give a special thanks to Louise Hand, Barbara Lyman and Sue Duggan and their teams who were involved in testing the resources to see if they were what was needed. So I just wanted to mention that before we moved on. So next slide, please. So if smoking isn't in the specification for this year, what is? So at the last event in March, I shared this driver diagram, and at that time it was in draft form, but it has now been confirmed and it hasn't changed, so that's brilliant. And what you can see from this, and I do appreciate it is a little difficult to read, but what it shows is that the drivers of optimisation and stabilisation of the preterm infant and the driver of the recognition and management of deterioration of women and babies, both of which were in the specification for the last year, have remained in the specification for this coming year. And as you can see, there's a green box there, and which talks about culture work. So those two work streams will be underpinned by the culture work. Now, nationally, I haven't got an update on where we are with that, but what I will do is, as information comes available, I will make sure that you get that. So next slide, please. So I wanted to talk about this driver first. So the driver regarding the management of deterioration, recognition and management and deterioration of women and babies. The agenda for this has very much been driven by the national team, but would like to say it's brilliant to be able to tell you today that the new tool, so the new 2 tool, so the newborn early trigger and track 2 tool, um, for trusts in our region, and I mentioned this last time, have been involved in the usability testing phase, but that is now complete, which it wasn't previously. So those trusts are Gateshead, North Tees and Hartlepool, Northumbria and South Tees. And the findings from the testing phase have been shared with the BAPM design group. So watch this space for next steps. Again, as soon as information becomes available, I'll share that with you. Also, Stuart, can you just go back? Thank you. The usability testing for the National Muse, so that's the maternity early warning score, is going to start later this month. So there's a launch event on the 28th of June, which is great. And again, it's brilliant in our region. We've got 3 trusts who've put themselves forward to be involved in this, and they are Newcastle, North Tees and Hartlepool and South Tees. So just a huge thank you again for taking time to do this. I do think, and I know I said this last time, but I do think it's great that the trusts in our region have been and will be involved in influencing the development of these tools. It's brilliant. We will be hearing an awful lot more about these tools this coming year. So again, watch this space. Next slide, please. So the other focus for this year is around the optimisation and stabilisation of the preterm infant. And as you know, we have been doing quite a lot of work around this over the past year. So just by way of a recap, we have 7 interventions which are on the screen there, which sit under this work stream. Now, these interventions, just to clarify, have been identified on clinical evidence and the national ambition, and it's an ambition, not a target, but the national ambition, and therefore what we should hopefully be striving towards is to achieve 95% compliance across all of the 7 interventions. So the other thing to mention here is that we should be looking at them as a pathway of care rather than separate interventions. And I think we do both, and I think that's good, but it was just to just make that point because it will be made later on as well. So next slide, please. So there has been a huge amount of work ongoing within this work stream, both nationally and regionally. So I covered quite a bit at the last event in March, so I'm not going to go over that again, but if anyone just wants to know about all the work which has been ongoing and you weren't able to join in March, do let me know and I'm happy to talk it through with you. So I'm just going to share with you the new stuff today. So the National MATNEO SIP team have been using North East North Cumbria data to look at developing a return on investment framework. And this is, I think this is really, really interesting. And I was hoping that Charlie would have been able to share some of that with you today, but unfortunately he isn't. But as soon as we've got further information on that and maybe a finalised framework, I'll share that with you as soon as it's available. They're also nationally looking to develop a mixed method evaluation of the preterm pathway. And this is to determine the additional benefits of all the 7 interventions being looked at as a pathway rather than individually. So I do have to say that's all I know about that. But again, to me, it sounds really interesting. And when information becomes available, I'll let you know. And lastly, from the national side of things, they're also in the process of developing some action learning sets. So the work which is happening across the country can be shared, which I think is brilliant because I think, you know, it's great for us all to have the opportunity to learn from other teams because, you know, we've got teams across the whole country involved in this. So should be great to hear what others have got to say as well. So as I've mentioned, I just wanted to highlight here that we do tend to look at the interventions as separate interventions. But as I said earlier, ideally, we do need to start, and we do a bit of this already, but look at them as a pathway of care for each baby in the not too distant future. I understand that we're going to be able to pull the data from neonatal BadgerNet, which I think will be really interesting around that. Stuart, could you just go back again? Thank you, that's great. So regionally, although we do need to look at these interventions as a pathway, some interventions do require more intensive focus than others. So I think we do need to look at them as a pathway, but also some do need a little bit more focus. So for example, those where the data is showing where the data isn't great. And as I said on numerous occasions, this could be because the data isn't being recorded accurately, or it could be that the intervention is happening, or it could be a mixture of the two. Unfortunately, until the data is correct, we simply don't know the answer to that. So last year, the Regional Optimal Cord Management and Normothermia Collaborative was set up, and that will continue into this coming year. The next meeting is actually next Tuesday on the 21st. So if anyone who's interested in being part of that but hasn't received an invite, please just contact me and let me know, and I'll make sure you get one. We're very welcome for anyone who's interested to come along. Now, we've seen some great improvements in optimal cord management, and I'm going to share the data with you in a few minutes, so you can see how much improvement has been made. Having said that, our data suggests that we don't do well for antibiotics and maternal breast milk. And again, this could be a reporting issue, or it could be that the interventions are not happening. We just don't know. I think a bit of it is definitely a reporting issue. So this year we are going to give focus to these two areas. So you will hear more about that in the coming weeks. So watch this space. And just as I come to the end of this slide, and I know I've mentioned this previously, but I do just want to make sure everyone hears the message. If as a trust you would like any quality improvement support regarding this work, please do contact me and let me know. I'm very happy to help and support with you. So now I'm going to move on to the data. As I've already mentioned, this is what neonatal Badger is telling us. So I appreciate that unless the data is inputted correctly, the data may not be 100% correct. But if we move on to the next slide, Stuart, thank you. But having said that, I think one measure we are clear about, we do know the data is accurate, is this is the place of birth. So I'm not going to go into this measure in any great detail. Now, as at previous events, what I'm going to share with you is the data in SPC charts, so statistical process control charts, and you're going to hear more about these charts in the measurement section later on this morning. So if you don't quite understand everything or you don't quite understand what the graphs are telling you, it will become much clearer as we move on through the morning. So next slide, please. So for steroids, this slide shows you two charts. So the chart on the left shows you data for babies less than 34 weeks who receive any dose. So that's any dose of steroids. And we have data for this going right back to January 2020. And what this, as you can see here, is that we haven't met that 95% ambition since about August 2020, but I'm not quite clear why that is the case. And if we look at the chart on the right hand side, this shows data for babies less than 34 weeks who received a full dose. So the graph on the left is any dose and the graph on the right is a full dose of steroids within 1 week prior to delivery. Now, this is the national measure, so this is what we should be working towards, but we have far less data for that. It's only just been in the past few months been available for us to pull off BadgerNet. So we've only got 5 months worth of data, but we will continue to collect that moving forward. Next slide, please. So this is the data for magnesium sulfate, and as you can see, there's been common cause variation, and Tony will talk about what that means since April last year. But basically, it's telling us that there's been no statistical changes, positive or negative, for quite some time. Next slide, please. So our antibiotics data, again, we've got two charts here. So the chart on the left shows you data for babies less than 34 weeks who received at least one dose of antibiotics. And again, we've got data going back to this since January 2020. And the chart on the right shows you, again, babies less than 34 weeks, but who receive at least one dose within 4 hours of delivery. So again, we've only got 5 months worth of data because it's only within that time scale that we've been able to pull the information off Neonatal Badger. But again, we will continue to collect that information moving forward. So the national measures, as I said right at the start, they've been set based on evidence that that is the optimum way antibiotics should be delivered, so within that 4-hour time frame. And what you can easily see from these charts is that we're nowhere near the national ambition. Now, I am pretty sure and I know for a fact that some of this is because the data isn't being recorded, but I don't know how much of it is because the data isn't being recorded into Neonatal Badger, and how much of it is that it isn't actually happening. So just something to think about there. And as we move on to the next slide, Stuart, so here we've got optimal carb management, and I said we've made some brilliant improvements in that, so well done to all the trusts who've been working hard at this. There has been quite a bit of focus on optimal carb management over recent months, and as you can see here, we've got a very statistical positive change which has been happening over several months, and this is fantastic to see. And we, as I said, we're going to continue to look at optimal carb management in this year because we, ideally we want to get nearer to that 95% ambition, but an incredible progress has been made so far. Next slide, please, Stuart. So I think we need to go back one. Have we jumped to? Yeah. So for temperature for preterms, you can see that we're near the 95%, but we're not quite there yet. And actually this chart demonstrates that there hasn't been any statistical change, again, positive or negative, since as far back since we started looking at this data in January 2020. Next slide, please, Stuart. So maternal breast milk, this is the national measure for babies under 34 weeks who receive maternal breast milk within 24 hours. So as you can see, we don't do very well on this. And again, I think, could you just go back, Stuart? Yeah, brilliant, thank you. That this, I do wonder whether this is a reporting issue. From discussions I've had with trusts, I think it is happening more. Well, I know it's happening more than it is shown here, but from conversations I've had with trusts, I would be surprised if we were quite near that 95% ambition. So I think that's something for us to work on. So as I said earlier, what you can see from these charts is that the data reported shows that we're making huge improvements in optimal carb management, which is brilliant, but we're not doing so well on antibiotics and maternal breast milk. So over the coming months, we plan to put additional focus onto those. So next slide, please, Stuart. So just to provide some further information, if you haven't already joined this yet, please do join the hub for all things MATNE or SIP across North East North Cumbria. We do have 116 members at the minute, which is fantastic, but it would be great to see more. So I will put the link in the chat for that after I finish this. And the date for the next meeting is, the next event is on the 21st of September in the afternoon. And again, I will put the link in for that into the chat. But so that would be brilliant. Oh, and Sarah's done that already, so that's great. Next slide, please. So You know, if you've heard anything today which you would like to get involved in, which you aren't already, please just send me an email. That would be brilliant. And we can make sure you're plugged into that. It would be great to have as many people on board as possible. So we just move on to if we've got any questions. So I can't actually see the chat, so I'll just go into that. Has anyone got any questions before we move on? Is there any other questions in the chat? I'll have a quick look. Right.
So Julia,
Tony.
there is a question from Rachel about what's causing the peaks and troughs, and it will vary from measure to measure whether we've got common cause or special cause, which we're going to cover in the measurement session. But it is a good question. One of the problems if we've got common cause will be that it is very difficult to identify what particular reason in any particular month is generating a change in the data, if it's within the control limits. So we are going to talk about that a bit more. Even if you've got common cause variation, though, it doesn't mean that we shouldn't be trying to improve the data. We'd be looking to bring the control limits in so that the amount of variation, the difference, if you like, between the peaks and the troughs is reduced. So it's a really good question, and I think it is difficult to unpick the actual specific cause on an individual month for most of the measures, because most of them are only varying by common cause. That doesn't mean we can't try and reduce those variations. And so the example you use, which is about common education, is exactly the sort of thing you might do to try and reduce that variation.
Excellent. Thank you, Tony. And yes, I will pop my email in the chat, so you've got that. So that is there something I can look at as a layperson around the Muse measures and what they cover, please? Well, we haven't got the Muse measures as yet. They haven't been shared nationally. Unless you know anything, Tony, I don't, but I don't think we have anything as yet.
I don't think they're yet in the public domain, but they are coming soon. And then there will be stuff probably, I think, on the college website. So the Royal College of Obs and Gynae website will probably be the place. But yeah, once they're published, there'll probably be multiple ways of getting to what's included.
And I expect we will be talking about them at one of these events. So, so yes, endlessly, I would say. So, if there aren't any further questions, I'm going to move on to our next section, which is Tony Roberts. So he's been helping answer the questions here. I think many of you will know him, but he knows a huge amount about deterioration and escalation. So he's the perfect person to do this section. Well, you are, Tony. And so I'll just hand you over to Tony, and he can tell you maybe a little bit about your background, maybe.
I certainly will. So thank you for that, Julia. I'm hoping that we haven't got automatic timings on these slides and that they won't jump as they were for Julia. If they do, Stuart and I haven't said next slide. Can you just go back as they move? Anyway, I am Tony Roberts. I come from a measurement background. I work as the patient safety lead in our North East North Cumbria Academic Health Science Network, and have done since the beginning of it, which was 2014, I think the PSC goes back to. I also work at South Tees Hospitals, as you all know, the acute provider in Middlesbrough, and I also have a role in something called NEQOS, the North East Quality Observatory Service, which is a data organisation, helps people to use NHS data for improvement and sometimes planning and research and so forth, but mainly for improvement work. My interest has been particularly in deterioration in adults, by which we usually mean non-pregnant ones. So particularly people who are getting physiological deterioration as detected by the National Early Warning Score. And a bit like Newt, it's got a 2 on the end now. So News 2 is the one that we would use in, elderly people or basically any adult over the age of 18 who experience physiological deterioration. So I am not an expert in women and babies. I have 3 children. That's about as much as I know. I was there. Didn't seem that hard. My wife would kill me for that comment. Anyway, let's press on, and next slide, please. So first thing to say is thank you very much to Kent Surrey and Sussex for quite a lot of the content of this slide. One of the things about being in a national programme is that we get to share across the country, and quite a bit of the information in here came from Kent Surrey and Sussex, and we can learn things not only within our region but between regions. So thank you to them. Next slide, please. Okay, so let's talk about escalation and the problem. So it's one of those things that we know is commonly identified as a problem when we've got review of cases of harm in both women and babies, and specifically in infant brain injury. We know that we've failed to identify, escalate and respond appropriately to deterioration. Secondly, we also know that there are problems around miscommunication and lack of standardized processes for transferring the critical information, particularly when we're talking about handoffs between team members. And if data or if information is lost during handover or between transfers and all that sort of thing, then that does tend to compromise patient safety. We also need to think about not just when a patient deteriorates acutely, there may have been opportunities to identify earlier that a person was at risk of being somebody who might deteriorate, and we're not brilliant always at that prevention side of it. So I'm going to talk about that again in a moment. And then the other thing that's clear from various national investigations is that it varies enormously between the various settings. So if you're in a tertiary, centre, you might see different problems to more, shall I call them, low tech environments, lower risk environments. We still see the same sorts of they're different problems, but we still see problems with deteriorations in all those settings. So we need to be nuanced about what the approach is. And we also know that in teams where there's a high proportion of new rotating locum or agency staff, this can be a particular problem. Next slide, please. Again, I'm not going to go through this in huge detail, but if you look at the national priority areas, so places like HSIP or saving babies' lives around fetal monitoring, or each baby counts, and Embrace and National Reporting and Learning System, and so on and so forth, they all identify escalation and deterioration in both women and babies as a problem. And you can also see it, I'm sure you're all aware, in the Ockenden reports around people who've had a bad outcome, and this being one of the key areas we need to work on to get better at spotting and responding appropriately. Next slide, please. So this is a thing called the PEER framework. It's a way of thinking about escalation and deterioration, so that you've got a kind of structured way of thinking about it. And it'll be summarized again on the next slide, but I just want to talk a bit about this for a few minutes. So P of PEER stands for plan or prepare. So we know that some people are at higher risk of deterioration, some babies are at a higher risk of deterioration. Knowing that up front before they deteriorate is really helpful, and we can think about that along care pathways. It's also about doing usually repeated risk assessments to spot people who are at risk of deterioration, and understanding, those people might need more monitoring. And then we've also got things like safety huddles, so that everybody, let's say in a team looking after women, let's say in a ward situation, know which of the patients who are most at risk of deterioration, and so that is communicated adequately, so it's not a surprise when it shouldn't be. Of course, it can happen out of the blue, but in lots of cases we know in advance that somebody is at risk, and we're not that great at communicating it to everybody who needs to know. So that's the P bit. The next bit is I for identification, and this is really where National Muse, so maternity early warning scores and NUT2 comes in, so that we've got standardized physiological and other observations used to identify it in a standardized way. And that helps everybody, particularly where staff are moving from unit to unit. There isn't some slightly different version of the scoring system, so that we have a standard way of knowing when people are deteriorating. And it's taken a long time, but we are going to end up with a national maternity early warning score. I think I'm right in saying every unit in our region has a Muse now, but we will have one standardized one. So if a member of staff works in more than one unit, they'll be using the same scoring systems so that we can, and the same escalation processes and so forth. So E is for escalation. And a lot of this is really about how do we communicate the risk that we might have identified with the scoring system, and that, or not, might be that you've just got clinical, the scoring system is helpful. It's a tool, it supports clinical decision making, but it's not the be all and end all. And so it may be that you're trying to communicate a set of obs, or it might be a more clinical judgment type of communication you're trying to do. But how do you make sure that that communication is received in the way that you meant to transmit it, if I can explain it that way? So we can use standardized communication tools to try and make sure that information successfully goes from one person to another, from one team to another, all those sorts of situations. And finally, response. So the last bit is about, well, let's say we've identified somebody who's deteriorating. We need a standard way of communicating that problem, and then we also want a more standardized way of responding. So how quickly does somebody need to come? What sort of level of person needs to come in terms of clinical experience and seniority? And it's also worth bearing in mind, I think, here that it is possible to get into a sort of what's the right way of putting this? A sort of view of what's going on in this case, and so that everybody's thinking this is what's happening as they go through that time. And sometimes a fresh pair of eyes will arrive and say, "Are you sure that that's really what's going on? Maybe it's this instead." So that's also a key part of it. That sometimes you can escalate to go, let's have another person have a think about what we think is happening to this woman or to this baby. So that's the steps. Next slide, please. They are summarized on here. So you can see this is the PEER framework. So plan, prepare and prevent, then identification, then escalation, and R for response. So I'll leave that just for a second. So for people who are reading it, you can see it, but hopefully I've explained it as I've gone. Okay, so next slide, please. So what we're going to do now is ask you to participate. And what we're going to do is ask you 4 questions. What we're trying to do is identify any themes that might be possible to support regionally. So are there particular things that we know can be a problem in terms of escalation that we can identify? What we're going to do is do something called a waterfall. And it's really a way of doing a survey in a really quick, easy way to do it now. So the way it works is we're going to ask you to write into the chat box. And what I'm going to ask you to do is write the question number. So you might write Q1 for question 1, then type your response to the question, but then don't press send. Just wait. And we're going to give you about 90 seconds per question. So it gives you a feel for how much. You can't write an essay, but you can say, even one-word answers can be useful. If you think X is a problem, you can write that word. If you can write a longer thing, then do so. And then I'll give you a little bit of warning and say we're about to press send. The reason for doing it in this way is that it means that everybody's voice is heard and you're not being influenced by what other people have already said. So yeah, giving a bit like doing a survey. You don't know what everybody else's response to the survey is. You just fit it in and then we'll press send. Everybody will send at the same time. We'll get a waterfall, hence the name, of all the answers. And then later after the event, not today, but after the event, we'll collate those and say, people thought this was a problem or that was a problem. And then we'll be able to think about which ways we can support change in those areas. I hope that makes sense. Is anybody completely confused and wants me to explain again? There is also, if for some reason Teams is not working correctly for you and you can't do it in the chat, you can see Julia's email there, and so that is our sort of backup. You can email your 4 question answers to Julia, and they'll still end up in this sort of consultation. If that nobody's waving at me and saying that's terribly unclear, I have no idea what's going on. So hopefully I've explained it clearly. So next slide, please. Okay, so I might give you slightly longer for this question, but I am going to put a 90-second timer up so I know. So what you do is write Q1 first. If everybody can write Q1 into their chat, but don't press send. And then I want you to write after Q1 your answer to this question. What behaviours need to be present on a shift to encourage escalation of a concern? Okay. So hopefully you can still see the slide if you can see that question. What are the behaviours that need to be present on a shift to encourage escalating a concern? Okay, and I'm going to give you 90 seconds, and I haven't started the clock yet. But I have now. I'll give you a 30-second warning in a minute. You've got 30 seconds left. Okay, so hopefully you've managed to do that, and if you could all press send, that would be great. We'll see if that's worked. Brilliant. I can see exactly what you'd expect, a waterfall occurring in the chat. Brilliant, thank you. If you've not quite managed to finish, don't worry too much. It doesn't, we will still collate it, and that's why we've written Q1 at the beginning, so we can find everybody's answers to Q1. So if you're still typing away like mad, then don't worry, keep going. Okay, I think we're about there. So thank you for that, and hopefully that worked. And we're going to do the same 3 more times. So there's a couple more still coming in. So, but I'm going to move to question 2. So this time, write Q2 and the answer to the question. So can you move us on a slide, please, Stuart? So question 2, write Q2 first, and then put your answer to what can stop you from timely and appropriately escalating a concern. And again, you've got 90 seconds. I'll give you a 30-second warning. 30 seconds to go. Okay, so if you can press send now, please. I forgot to say earlier on, I think, that once we theme these up, these will be anonymous. You will be able to see these in the chat for a while. If you want to sit and read everybody's comments, you will be able to, but the intention is not, we're not going to report so-and-so said this and so-and-so said that. What we'll be doing is saying, it looked to me just from clicking as the chat came past me that leadership was a key issue in question one. So we'll say something about what your views on that were. And so we'll give anonymous feedback about themes. Okay, looks like that case finished. So can we move to question 3, please? Same again. Put Q3 first and then your answer to this question. How easy do you find it to challenge when a request for escalation is not listened to, and why? I'm giving you a little bit longer on this one because this is a slightly longer answer, I suspect, for many people, and partly because I forgot to press the timer. Okay, last 30 seconds. Okay, press send now, please. Yeah, as anticipated, these are slightly longer answers, aren't they, I think. So on the grounds that people might still be typing, I'm going to just give you a little bit longer. Okay, so if you are still typing, do keep going, and that is useful for us. So what we did was have a guess at the questions that would elicit themes that we could potentially act on across the region. So our last question, we've asked a much more open question. So Stuart, can I have the last question up, please? So this is much more open. Question 4, you can just say anything you like about what other issues are important in escalating a concern. So anything at all that you think we haven't perhaps covered already in the previous 3 questions, and you've got 90 seconds. Thank you. Last 30 seconds. Okay, and if you can press send again for Q4. Lots coming in, thank you. Can you move on the slide as well, Stuart? Okay, I think they're probably all come in more or less. If you are still typing, keep going and press send. But just to say thank you for everybody for participating in that, and I hope you managed to get your point in 90 seconds. It's quite a tough ask. Depends on how good your typing is. As we've said, we'll collate the information, identify themes, and then we'll feed that back and give some idea of how we can support any of the issues that we've identified as a region across the North East and North Cumbria. Okay, thank you very much. And I'm going to hand you back to Julia.
Thank you very much, Tony. That's great. And thank you for everyone who's put information in the chat. There's some really good stuff coming out there, which I think we'll be able to, there's definitely themes, which is excellent. So leave that with me. We'll collate it and we will make sure that is shared back as well. But as I say, it will be shared anonymously. So thanks again for your comments. What we're going to do now is take a quick 5-minute break, and then we're going to come back and we'll start the last hour of the day. Right, so if we just take a break now, come back in 5 minutes or at 10:30, that would be brilliant. Thank you, everyone. Right, I think it's past, so hopefully pe people have come back. Excellent. So, we're going to move on to this session, which is all about measurement matters. As I said right at the beginning, if you could make sure you've got a sheet of paper, an A4 sheet of paper, and just a pen and paper as well, because we're going to be doing some bits and bobs as we go through these sessions. So what we're going to start with is a presentation I developed earlier, and Tony's got a recording he's developed earlier as well. And the purpose of this is, if you were at the last session, you'll know that we're trying to develop a kind of suite of bite-size quality improvement tools and techniques which you can use. So we're sharing them throughout these events, but also so you can revisit them, as well as obviously some other information which we do around that. So I'm just going to hand over to Stuart, who's going to play the first video. Hello, this session will cover an introduction to measuring for improvement. The first question is to ask why measurement is important. In a nutshell, it helps us identify where we are and where we're going and helps us make better decisions. Without measurement, it's very difficult to know whether we've improved or not, or whether we've achieved what we set out to do. So I'm going to share with you a film clip which lasts about 10 minutes, and it's an excellent introduction to measuring for improvement.
Hello, I'm Mike Davidge, and I'm going to talk to you about measurement for improvement. So why do we measure? Well, it said there are 3 reasons why we might do that, and the first is very familiar to those who work in the NHS. This is a form of measurement where we have to achieve a particular target, often given to us by other people, using data that again often is given to us by others, or at least we're told what we need to collect. In its worst form, this leads to a tick box mentality, and achieving the target becomes the end in itself. The second is familiar particularly to clinicians, and that's when we're trying to discover new knowledge. For example, when we're trying to assess whether this new drug is worth investing in. And this involves a well-constructed trial and collecting lots of data to enable us to distinguish between the effects of the new drug and the existing treatments. Now, measurement for improvement is neither of those. So, what is it? Those of you familiar with the model for improvement will know that it asks 3 questions. What are we trying to achieve? How will we know that a change is an improvement? What changes can we make that will result in the improvement we're looking for? Now, measurement for improvement is aimed specifically at answering that second question. We're trying to see whether the changes we're making to the service we're involved with are actually moving us in the right direction. In other words, are we moving closer towards achieving our aim? So how does this happen? Well, good measurement doesn't just happen by chance. We need a good process. And I'm going to outline to you the 7 steps that make up this good measurement process. Step 1, decide aims. It's surprising how many projects start off with aims that are too broad or too vague. And this leads to problems when we're trying to measure the effect that that particular project is having or has had. So try this simple exercise. Imagine you're getting into a lift with a colleague and you're both going to the 3rd floor. And you've got the amount of time it takes the lift to go from the ground floor to the 3rd floor to explain what it is that project's trying to do. If you can do it in that time, then you have a good grasp of what you're trying to do. Step 2, choose measures. If we simply list all the different things we might measure, we often come up with a list that's quite large, and it's difficult to know which are the most important. And so there are a couple of techniques that do help you to structure that list of measures that you might have come up with. One is to look at the map of the process that you might have completed as part of the earlier stage of the project. Looking at that process map may give you some ideas about where the most important points are that you might want to pick up. The second, if you have constructed a cause and effect or a driver diagram, you can use that as well to focus in on where you might select appropriate measures for your project. Step 3, define measures. We've chosen the measures we want to use, and now we have to be clear exactly what we mean by them. Let's take an example. We've decided we want to measure complaints. Well, exactly how will we do that? Are we talking simply about the number of complaints received? Are we talking about the percentage of patients who complain? Are we talking about the number of complaints we receive per patient? Taking time to define your measures is important because it provides consistency over time. We've now come to the end of the preparatory phase of those 7 steps. And now we move into the collect, analyse, review cycle. Step 4, collect data. So we need to establish what data items that we need to collect. In our example about complaints, we've gone for the percentage of patients who complain. And so in this case, we'll need to collect the number of patients who complain and the total number of patients. And who's going to do it? We need to be clear whether it's ourselves or whether we're delegating that responsibility to somebody else. How are we going to collect the data? Are they from hospital systems or other sorts of organisational systems, or are they through bespoke surveys? When is the data being collected? Are you doing it real time, or are you looking back over data that has already been collected? And finally, when we're embarking upon a project, we want to know how we're performing now, to act as a baseline against which we measure our progress. And therefore, collecting data to establish that baseline before we get into any improvement is important. Step 5, analyse and present. The way that you present your data has a crucial impact on the way you react to it. So choose your methods carefully. For data about numbers, that is quantitative data, then you'll do that by turning your data into charts. And there are 2 types of charts that are useful to you here. The first is the run or SPC chart. This helps you to answer the question, how am I doing? Have I improved? A useful further tip is to annotate those charts with the changes that you make when you made them, so that you can see that the change resulted in a difference. The other type of chart is the bar chart, or sometimes called the Pareto chart. You use this to help you understand what are the causes of the particular thing you're looking at. So for example, back to our complaints measure, the Pareto chart is really useful to help you understand what are the most common complaints, and therefore where might you tackle next in terms of making an improvement. For data about words, that is qualitative data, then you might want to display that in terms of a story, a video clip, perhaps a storyboard. That helps to get the message across about what that data that you've picked up, perhaps from patient stories or interviews, is telling you. Step 6, review measures. The purpose of collecting our data is to help us make better decisions. That doesn't happen by chance. We need to make time as a project team to look at our data regularly and decide what to do next. Are we getting the outcomes we're expecting? What is the data telling us about changes, good or bad? And finally, so what do we now need to do? Step 7, keep going. And the final step tells us that we should go back to step 4, to collect, analyse and review again. In other words, go round that collect, analyse, review cycle. So how often do we do it? Interestingly, when I ask people in courses and seminars about that, they often say monthly, because that's the natural cycle of reporting in the NHS. But there's nothing magical about that monthly cycle. In fact, a weekly cycle of collect, analyse and review is much more useful, because a week is a much more discrete time period and people can often relate to what happened in a particular week, which helps to put the measurement into context. And how long do we go round this cycle? There are certain measures that you might be using, particularly measures of process, that once you've achieved a certain level, for example, percentage reliability that's consistently around 100%, you can stop collecting that data. There are other measures, and particularly often this is measures of outcome, particularly patient outcome, that you want to continue measuring for as long as that service exists, because those measures define how well you're doing in that service. And finally, looking at this data and understanding what it's telling you will always tell you when that particular project has reached its aim, and therefore it's time to stop and move on to something else.
I wanted to highlight a few key points, some of which have already been touched on in the film clip. The film clip covered the 3 reasons why we measure, and this presentation focuses on measuring for improvement, so not measuring for judgment or for research. Because we're focusing on measuring for improvement, we need to seek usefulness, and we need to remember measuring for improvement is not a research study. We should only measure what we need to, otherwise it will take you away from the time you can spend on implementing and sustaining your improvement. And the last point I want to make on this slide is to make sure that those collecting the data understand why they're doing so, because we often find that people are far more invested in collecting data correctly if they understand this. So one of the first things you need to do is to ensure that you have a clear aim or goal of where you want to get to, and that this should be SMART. So it should be specific, measurable, attainable, relevant and time bound. And you need to be clear as to how you're going to measure your aim or goal. So if this information is readily available, that's excellent. But if not, you need to think about how the data will be collected. The other thing I wanted to talk about is that when making changes, you probably want a suite of measures, which include outcome measures, process measures, and balancing measures. So if we talk about outcome measures first, you would usually only have one outcome measure, which relates to your aim. And outcome measures gauge how well you're doing in reaching your overall aim. And I'm sure a number of measures spring to mind which have been set nationally, which you're working towards. But it's also important to measure those key processes, actions or tasks which help you meet your aim, because if they're not right or if they're not working well, you're never going to reach your aim. So process measures track how well things are progressing, ensuring that the changes you are making are working to support reaching the overall outcome aim. And next we have balancing measures. Making changes to systems and processes often impact on other things, so you need to give some thought to if the changes you're trying to make will do this. And balancing measures help you understand if the changes made are impacting negatively elsewhere. So for outcome measures, how do you decide what they are? Well, as I mentioned earlier, sometimes a national target or ambition is set, and other times you know there is a gap and you want to bridge that gap. Identifying process measures might seem a little daunting at first, but actually it's not as difficult as you may think. If as part of your improvement work you have developed a process map or a value stream map, do spend some time looking at this to decide which tasks or areas are critical to reaching the outcome. If you've developed a driver diagram, again, it might be quite clear as to which primary or secondary drivers need to be measured. And of course, if you're implementing your change or changes using small cycles of change, so PDSA cycles, for each cycle you will have a measure, even if this is on a very small scale. So examples of simple process measures might be whether the right information is collected at a patient's first appointment, or whether the right tests are done at a particular point in time, or another might be the number of staff trained in a particular intervention. Now, these measures will vary hugely depending on what changes you're looking to make. So moving on to balancing measures, the key point here is that you need to consider how your change will potentially impact on other parts of the system. If your change doesn't impact in any way, then you don't need a balancing measure, but if it potentially does, then you do. A very often used example of this is where there is a wish to get patients out of hospital as soon as possible, and a balancing measure would be the number of readmissions. So I don't want to teach you how to suck eggs, but I did think it was worth mentioning that measures can be quantitative and qualitative. We see a huge amount of quantitative data in the NHS, so data in numbers and graphs, and examples are SPC charts, bar charts, timed observations, or how long something takes, and we see benchmarking a lot, and also surveys with closed questions. What we also see, but not as often, is qualitative data, so data in words and sometimes pictures, and such information can be collected through surveys with open-ended questions and also discovery interviews, particularly with staff and patients. Some of you may remember when we did the SCORE culture survey, there was a large number of closed questions, so quantitative data, but there was also space to add in any additional information, so written qualitative data. But we also brought people together to discuss the findings in further detail, so again using qualitative data. So when deciding on measures, you also need to consider which type of data is best used, and usually this is quite easy to identify. When you're first looking at measurement, you need to consider the following things. Firstly, what is the measure and why is this measure being chosen? What type of measure is it? I've mentioned previously we need a suite of measures which include outcome and process measures and sometimes balancing measures. Then what is the operational definition? So what is the numerator and the denominator? And are there any exclusions? So these questions are really key to ensure everybody understands what is being collected and why. The next set of questions relate to the how. So how is the data going to be collected? When and how often will the data be collected? And who is going to collect the data? And also what happens when they're on leave or on sick leave? How will you present the data? And who needs to see the data? And how will this data be shared with them? Now these things really need to be thought through and shared with those who are involved in the process. So I wanted to share this with you, and I love this picture, but unfortunately I don't know who developed it, so I can't attribute it to the person who did. But what I love about it is that it shares the process of starting off with data, which is often just a lot of numbers, and then you start making sense of the data through sorting and arranging it, and then the data needs to be presented in a meaningful way. So this is the sharing of information visually, but also sharing the story about what that data is telling you, so you bring the data to life. So when you're thinking about what to do with your data, think about these 5 steps. And a key point I wanted to mention here is that data can be deceptive if it's not presented in the right way. So this graph here looks like a great improvement has been made within 3 months, but the reality is that it hasn't. The reality is that the data is actually showing no improvement at all. This brings me to the end of this session, but for further information on measurement, please refer to the Understanding Variation film clip, which forms part of this series, and also there is a section on measurement in the HSN Improvement Toolkit, which is worth a look. And of course, if you have any queries, please do contact Julia Wood using the contact details on this slide. Thank you. So everyone, I hope you found that useful and interesting. Obviously, some of you would know quite a bit of that, and others it will be new to you. So I hope that has been helpful. What we're going to do now, I said you would need some paper. So what I want you to do is get your sheet of paper. Now, this sheet of paper, I'm not going to ask you to write on it, but you probably won't be able to use it afterwards. So make sure it hasn't got anything important written on it. So it can be plain. Plain is probably better. And what I want you to do is just follow these instructions. So pick up your sheet of paper and hold it in front of you, just like this. Now, I would like you to close your eyes, and then I want you to follow the instructions I give you. So hopefully we're all ready and you've got your sheet of paper in front of you. So the first thing I want you to do is fold your sheet of paper in half. Please remember to keep your eyes closed. Now tear off the upper right hand corner. I'm doing this as well while we speak. Fold it in half again and then tear off the upper left hand corner of the sheet. Fold it in half again and now tear off the lower right hand corner of the sheet. Now what I want you to do is open your eyes and open your piece of paper. So it's back to an A4 sheet of paper. Stuart, if you could take down the presentation, that would be great. And if people could just pop their cameras on at this point, that would be really helpful. Yes, that's great. And I want people to start showing their sheets. Right. So they all look a bit different, don't they? So if I'd done a good job of communicating and you'd done a good job of listening, then all the sheets should look the same. But as you can see, they don't. So why is that? Has anyone got any thoughts? Could put in the chat why they think that hasn't happened. Is anyone right? So you didn't say which direction to fold it in. That is true. Blind leading the blind. That is also true. It's all down to interpretation of the guidance. Everyone's interpretation is slightly different. Not clear, concise, not enough details. Yeah, you're concentrating, listening and trying to do the task. Everyone approaches tasks in their own way. Not enough detail. Yes, so the thing is, when you're doing measures and people are being asked to do measurement, people need to be really clear. So about what they're doing. Otherwise, it does go wrong. And I cannot tell you how many times that people have thought that they've given clear instructions and actually they haven't. So I asked you to close your eyes for a start. Now, you know, often we just tell people how to do something. We don't show people or give them proper instructions on how to do it. So I think that is a key thing to think about there when you're asking people about measurement. My instructions could be interpreted in different ways. So what I felt made absolute sense to me. Obviously, didn't make sense to everybody else. So what you need to do is sense check. When you're asking people to give measurement, you need to sense check that. I also didn't give you time to ask any questions. So how often do you get asked to do something and there just isn't time to sort of clarify anything? So there wasn't any time to clarify. So you just do the job, don't you? Hoping for the best that it'll all work out right. So I think the other thing is when we think about the MACNI or SIP measures, we've had numerous discussions about the measures with this and also about where the data needs to be pulled from, where it needs to be inputted, also what the exclusions are, and you need to write all this down when you do a measurement. It's really important. So the purpose of this, the point of it, of that exercise is really just to make the point that communication is really key. Because what you don't want to do is find out 6 months down the line that the data you've been collecting isn't correct and people have been collecting different things. And think back to that slide in that film clip, which I did, which says make sure everyone knows what they're measuring and who is doing what. So we're now going to move on to Tony's session. So if we could bring the presentation back up, Stuart, that would be fantastic. And thank you all for your engagement in doing your sheets of paper.
Hello, my name's Tony Roberts. I'm going to talk to you now about understanding variation and statistical process control. You're going to need a piece of paper and a pen. So I'm going to talk to you for a moment or two while you find those. So statistical process control can sound quite intimidating, but really it's an old set of techniques from the 20s and 30s, and it's really a very visual method. So don't be put off too much by the word statistical. It's really going to be quite simple to understand. And what we're going to do is a little exercise just to get the basic ideas across. Okay, I'm really hoping you've got a piece of paper and a pen. If you haven't, you can just do it as a thought experiment in your head. That's okay. So what I'd like you to do is write the letter A, about half a dozen or so, in a row across your page. If we were all together, I'd then get you to show them to each other, but you're probably sitting at home alone. It's sad, but such is the world post-pandemic. So I'm hoping you've got a little row of A's now across your page. Okay, have a look at them. Do they all look the same? Handwritten A's? There's probably a bit of variation there, isn't there? So some of them can look really neat and tidy. Some of them maybe look a bit ragged. Any of you who've seen my handwriting will know that all of mine look pretty ragged, but some worse than others. You could even put them in a rank order if you wanted to. You could say, well, that's the neatest one. That's the sorts of letter A's I'd like to be able to write all the time. And some of these over here, I'd rather forget about. What do you think causes the variation in handwritten A's? Well, it could be maybe something to do with the pen. Let's blame the pen. Maybe you've got one of those dodgy biros that doesn't really flow the ink very clearly, or it's a bit scratchy. Maybe it's the cheap piece of paper that the NHS has provided you with. Maybe if you had a beautiful fountain pen on a beautiful piece of smooth letter writing paper or something, that would be better. Maybe. Or maybe it's more to do with you rather than the pen and the paper. Maybe you got distracted for a moment. Maybe something happened outside your window and made you lose concentration for a moment. Or maybe it's something physiological. Maybe it's the C fiber firings, controlling your muscles that, creates a little bit of variation all the time. We could go on. There's probably dozens and dozens of reasons that could be behind little bits of variation. And if you want to tell why that particular A looks good and that particular one looks terrible, you probably have no way of telling which of those factors might have caused the change. Now, I want you to do it again, but this time I'd like you to use your wrong hand. And I mean by that, if you're a right-handed person, use your left hand. If you're a left-handed person, use your right hand. Okay, so just again, about half a dozen little A's along will look fine. Okay, hoping you've had a chance to do that. And again, if you need to just do it in your head, that's okay too. So this row of A's, are they better or worse? Is there more variation or less? I'd suggest that for most people, unless you're ambidextrous, they tend to be a bit worse. And why is that? Well, it's probably to do with practice, isn't it? Things that we do multiple times, we tend to be better at, and we tend to be more consistent. So writing with your right hand, you might have terrible handwriting like mine, but my left-handed A's are even worse, even more variation. Okay, one last little row of A's. I want you to draw a row of A's with your good hand, your right hand if you're right-handed, your left if you're left-handed, and slip in a wrong-handed A. So swap hands somewhere along the row and do a little A somewhere in the row. Again, half a dozen, 10, whatever, A's. Okay, you had a chance to do that? Okay, now look at that row compared to the two above. For most people, not everybody, but for most people, the wrong-handed A really sticks out. You can spot which one is the one that was done with your wrong hand. Again, if we were together in a room like we used to do with trading, I'd get you to show it to a neighbour and you'd be surprised how easily your neighbour can spot your dodgy wrong-handed A. So we've got variation in the rows and we've got spottable variation when we switch hands. So I'm just going to use that to illustrate these basic concepts of variation and statistical process control. So, and there's a bit of jargon associated with this that you just want to get your head around. So, variation is always normal. Okay? It's just inherent in all systems. Suppose I want a really, really good row of A's. Maybe handwriting is not the way to go. For example, I could use one of those 1940s old-fashioned typewriters with a ink ribbon, couldn't I? And just bang with my index finger a series of A's. Would they be all the same? Well, perhaps in normal life we'd say they're all the same, but actually if you look at them carefully, perhaps with a magnifying glass, you'd see that actually the amount of ink that stuck each time you banged the key is slightly different. Less variation than handwriting, but still variation. Suppose you now think, well, we've got computers. Let me have a row of A's that I type into Word, and then I'm going to print it onto, laser quality photographic paper and print that out. Surely all the A's are going to be the same then. Well, again, in normal life, of course, we'd say they're all the same. But if you really wanted to look at them, and you might need a microscope now, you can look, and there will be small differences between the rows of A's. So all systems produce some variation. It's really about deciding how much variation we want and what kind of variation it is. When it's affecting all of the A's in our example, or all of the outcomes, all of the process parts of a system, then we're going to call it common cause variation. So this was a term invented by W.E. Deming. It's called common cause variation. And slightly earlier, a chap called Walter Shewhart invented this, used to use the term unassignable. So he'd say, out of all those lists of things that cause variation, we have no idea which one is making the change between one example and the next. So it's an unassignable cause or a common cause variation. Okay, so that's the first kind of variation we're interested in. Sometimes though, We're not saying that kind of variation. This is like your wrong-handed A in your row of right-handed A's, correct-handed A's, okay? So the factor isn't present all the time. It's not affecting all of the A's or the outcomes or the process itself. It's arisen because of specific circumstances. In this case, you swapped hands, okay? And we're going to call it special cause variation in Deming's language, or assignable cause variation in Shewhart's. So we know why that particular A, that wrong-handed A, is worse than all the correct-handed A's. It's because we swapped hands. So we're going to give it a special cause variation, or we're going to call it assignable cause variation. Okay, and that's it basically. Statistical process control is designed to help you identify these two types of variation. And we haven't used any numbers at all, have we? This is completely a visual display method. And most people are really good at it because human beings are great at pattern recognition, and clinicians tend to be especially good at it because part of what you're trained in is looking at patients or results or all sorts of things and spotting variation that's abnormal. Now, why do we need to be able to distinguish the two kinds of causes? Well, if we muddle the two up, our approach to reducing variation, which is often what we're trying to do in healthcare to get quality improvement, we will make mistakes. So the first step is to try and change or control or eradicate assignable causes. So things that make the system that you're looking at less consistent. Okay, and the reason for that is because assignable cause variation is often very unpredictable. We don't know when the next one's going to come along, and it means that we can't have a stable process that we can manage easily. So if we find we've got an assignable cause, then we try and figure out what's causing it. So we want to look as soon as possible. I should perhaps add here, 95% of failures are due to the system. This is a quote from Deming, really. He's a system quality improvement guru, really, management guru. So he's saying, look early, look for a data problem. So long ago, when we used to measure jaw to balloon times in primary angioplasty, sometimes you would get a huge time between somebody arriving and them having a balloon inflated in their coronary artery. And you'd realise that what had happened is somebody had made a keystroke error and put the wrong date in. So we get 24 hours worth of extra time put into the data. So special cause, it's an error. It's a data error. And the NHS is full of data errors. It's the commonest reason for a special cause. So you're trying to eliminate data problems. If you're convinced it's real, then maybe it's something to do with the case mix. Maybe this patient took ages to go to theatre, let's say, because they needed special workup. So they're different from the normal patients going into that system and going to, let's say, theatres. Or it may be that something wasn't available. A scanner was broken, or the staff to run something weren't available. And so that's changed the process. Maybe something about the process itself, people just didn't follow the method that we normally use. So it could be to do with that. And then very last of all, and this is a hierarchy, this list, you'd check the individual. Maybe the individual just made a mistake and didn't follow the process that we're supposed to use. So you'd look for all of those, try and understand what's caused them. If it's a thing that's fixable, you would try and fix it so your process can be free of assignable cause variation. And if it's not, if it's something, let's say, to do with patients and the choices that they make, then you might have to live with it. But at least you'll understand what's going on in the process. Okay, so we're going to try and tell the difference between special cause, common cause variation, assignable, unassignable. And we're going to do that using a method that does involve statistics. So hence the name statistical process control. There is no perfect way of doing it. There's always a trade-off between failing to spot a real difference and falsely saying there's a difference. But we try and agree in advance what we're going to use as our standard. It's usually a thing called 3 sigma. I'm not going to cover today anything to do with how these things are calculated. For the vast majority of people, you're just going to be presented with a chart with all the calculations done. And that's what we're interested in talking about today, not about how to do the calculations. On another day, if you really want to, I'll tell you how it's done. The other thing I want to just touch on briefly is there are 2 types of control charts. Okay, what I'm going to call a time chart, and there's also a thing called a funnel chart or a funnel plot. Okay, so in a time chart, we've got a single place, single unit, single hospital, something like that, but lots of measurements through time. So one place, lots of different time periods. Alternatively, we might have one time period, let's say a year's worth of data, and lots of different places, and we want to see if there's variation between the places. Okay, so they're the 2 kinds of charts we're going to be interested in. So I'm going to start with time charts. So this is a very old slide, but let's imagine we're trying to count the percentage of patients with a particular outcome. Okay, and we're going to say the less this outcome happens, the better. Okay, and so what we do is we plot every week the proportion of patients who have this outcome. And in the first, on the left hand side, in the first part of the graph, you'll see there's a dotted line marked mean. So the average number of times that this happens, it's about 16%. Okay, and you can see that from week to week you just get a bit of variation. It wobbles around because it does, because there's common cause variation. However, you can see on the 8th of June 2003 we had a score that was much higher. It went up above the dotted green line, the upper control limit, and so it's likely that something special happened. A special cause variation happened then. Okay, and then after that it went back inside the control limits, and we've probably got common cause variation from there on. The second thing we can do is think about, well, that amount of variation is difficult to manage, difficult to staff for, it's a problem. We would like less variation. And so let's say we do some brilliant improvement work and we try and change the process so that it works better. And actually what happens over the next 7 weeks is that the number of people who get that outcome is lower. If we get a run of 7 points below, we go back to when that started and we recalculate the mean. So you can see on the right hand side the mean's dropped a lot. It's dropped to about 5%. Okay, and now we've got points, they're still wobbling around, there's still variation, there's still common cause, but all of the points are lower than the upper control limit. Okay, the upper control limit's running at about 12%. Suppose we have some sort of target line, perhaps a benchmark, some reason to think 10% is achievable. If we want this process to deliver 10% of this outcome in our patients consistently, then we're going to need to try and get our upper control limit to below the target line. So we're trying to get that green dotted line to get down to the 10%, and then we can be pretty confident that provided a special cause doesn't come along, this process will routinely produce 10% of patients every week or less getting the outcome. In fact, on average, it'll be quite a bit less than 10%. It's probably going to be 4-ish%, but we can be sure that you'll never have a week that has more than 10% unless there's a special cause. Okay, I'm hoping you've all followed that. And I'm going to move across to funnel plots. Same sorts of ideas really going on, but this time we're going to take one chunk of data, let's say a year's worth of data, and we're going to compare different units. Okay, so each of the dots represents a different place within that year's data, and you can see all the dots are scattered around the average, which in this case is running at a little bit over 1%, apart from one unit which is well above the control limit, the upper control limit. That's the curved red line. It's running at 3%, and so we can say there's something special about that hospital. We want to understand what's different about them. Okay, whereas all the others are, although there is differences between them, they're going to be common cause, and so if we search for a reason, we're going to struggle to know what that difference is. Okay, so we're nearly there. There is a group of people in NHS England who are promoting this sort of thinking. They're called the Making Data Count team. They have a site on Future NHS. There's a whole series of videos and materials and tools and all sorts of things. There's a discussion forum, all sorts of things. Brilliant site. We'll talk you through more about this, but you have already got the basics of statistical process control. Okay, but I'd recommend you go and have a look at that site. Easy to register and find. Okay, this is my final slide. The techniques we've been talking about can be used at a very, very simple level. So I've done it where we've counted something easy on a ward with a 5-bar gate, totted that up in Excel, made a graph. Very, very quick, very easy, very simple way of looking to improve a particular process. And there's absolutely nothing wrong with that approach, and in some circumstances that is the way to go. But obviously we've also moved into a world which is much more digitally enabled and will continue to get more and more digitally enabled as we use clinical systems and other systems to record the care that we provide in things like Badgernet, and we've got it in our PAS systems and in our imaging systems, our lab systems, all sorts of places. So I just want to talk very briefly about a thing called the Goldacre Review, run by Professor Ben Goldacre, who was commissioned by the Secretary of State to make recommendations about how we can use the NHS's data for planning, for improvement, but also for research. There's a great website, goldacrereview.org. The report itself is very long, 280 odd pages, 180 odd recommendations, but there are summary versions, and for those of you who are interested in this particular world, particularly if you're involved as a data analyst of some sort, well worth understanding what he's saying about how we will build the infrastructure and the skills to allow us to do this sort of work using data that's collected as part of clinical work itself. The Secretary of State will publish a data strategy, I believe, in 2022, which responds to the recommendations of the Goldacre Review, and so we'll have an understanding of how this is going to work in practice as we go forward. And lots of people who want to use this data will want to use it in SPC format when they're thinking about improvement. There's a whole other world around research and planning and so forth, but this is a way that we could take our data and do it perhaps across the region and understand how we can improve the delivery of care, which is what obviously the maternity and neonatal safety improvement programme is all about. So just a quick plug and mention for Goldacre for those of you who want to get into the details of how we might do this in the future. Thank you very much for listening, and I hope that was a helpful introduction.
Thank you very much, Tony. That's great. I think, shall we pull the slides down because you wanted to just mention something else as well? So thanks again, Tony. Stuart, if you could just pull the presentation down, that would be great. Thank you.
Yes, I just wanted to add something. So I recorded that talk on the last day of May, and you'll have seen that I slightly hedged my bets about when, see, that hasn't worked, about when we were going to get the data strategy in response to Goldacre. and again, for many people, this won't be enormously. Actually, I don't think I've got. Oh, hang on. Yes, we have. There we go. This won't be enormously relevant, but I know there are a few people around who maybe are interested in this topic and want to know the details. But the Secretary of State published this week the latest version of the Data Saves Lives strategy, which is the response to Goldacre. And I'm going to pop the site into the chat for anybody who does want to see it. Again, like Goldacre itself, it's very long and very detailed. So I think that's hard to avoid on a data strategy, but it does explain how it's going to be done. My personal recommendation, if you really do want to look at this, is Annex B lists the commitments. So it explains how this is going to work and how, in effect, how the NHS is going to respond to the Goldacre reviews, all sorts of things, from how do we handle people who do not want their data used for this, so the opt-out system. So you may have women who say have made a choice, perhaps in general practice somewhere, and said, actually, I don't want any of my data used for any of this. So what do you do about that? There's a commitment in there, and then there's loads of stuff about infrastructure and skills development for how we're going to do this across the region, and particularly the maternity network and the neonatal network will help us develop some of this for our region, so that we can use data that you've collected just by doing the clinical work as part of recording of care of individual patients. That will be sucked off into this infrastructure, and then we'll be able to report back to you whether you gave antibiotics or steroids or so on and so forth. So I just wanted to make that quick point that that data strategy is now out. Okay, thank you, Julie.
Thank you very much, Tony. So hopefully through that measurement session, for those of you who maybe were a bit wary of measurement, that you're not so wary of it now, and for those who love measurement, hopefully you've also learned something too. So the other things we've covered today was the overview of the MATNAO SIF, so what's happening nationally and regionally, and also the session Tony led on escalation for the management and deterioration of women and babies. So if we don't have any further questions, I just wanted to say a few things. So firstly, thank you very much, Tony, for your presentations. That would be great. That's been great. So thank you for that. I also wanted to apologise to Stuart for the first presentation, which I did. We seem to have timings put on the slides, which is obviously something to do with me, but I didn't know about it. So sorry for all the to and fro with that, Stuart. And obviously a huge thank you to Sarah, who sits behind all of these events and does an amazing job of making them run smoothly. Even when I mess up, she makes them run smoothly. So that's really great. I think we've got a question in the chat. We would be keen to link in with other networks regarding developing a data strategy. Have you got any comments on that, Tony?
Yes, so Newcastle are one of the sites that are really key to all of this. So the strategy talks about secure data environments and how we will have an ecosystem of these things. We've got a really strong interest in this in the North East, and the North East has set out a strategy under the ICB, the new arrangement, the Integrated Care Board, which oversees the integrated care system that we're all moving into very shortly. About how the North East becomes the best place to have your care, partly because we're good at data, we're good at research. The pandemic's really changed things. You know, we actually, as I was driving in this morning, they were talking about the recovery trial and how that identified methotrexate as a treatment in COVID, and more than 1 million lives saved because of it across the world. So we want to be a place that is particularly good at this. So Terry, here, are you the Terry Phillips I know? I suspect you are. In which case, drop me an email and I'll connect you into the discussions. There's all sorts of discussions going on about this.
Thank you very much, Tony. So if we haven't got any further questions, I think we'll bring this session to a close. I said we'd finish by 11:30 and we have, so I'm really pleased about that. So thank you for joining. We do have an event in September and the link will be sent out with the details which Sarah sends out following this event. So enjoy the rest of your day and the rest of your week, and we'll see you again soon. Thank you.